good morning. I'd like to personally congratulate you and Marconi for an excellent meeting, and of course, humbled to be invited. Not to worry, we saw how you can fix LASIK complications, you saw how we can fix smile complications. Let's see what we can do with topography-guided ablations. I do consult for several companies that develop exomer technology, and some of the diagnostics I'll be presenting to you today. All laser vision platforms today are unparalleled. Laser refractive surgery was never better than it is today. Standard, wavefront optimized, asphericity adjusted, wavefront guided, topography guided. I'll be speaking about that, ray tracing, and we heard about SMILE. It's difficult to do this in 6 minutes. We give an 8-hour course, a whole day course on some of these principles that bear significance in the diagnostics. Clinical question. This is right, left eye of a patient. We can see here the topographies. We can see the sign fluke imaging. Both eyes are 20/20. Which eye, and we can go a little bit in the previous talks, would be best for cataract surgery? This eye, the left eye, or the right eye? We'll talk about that a little bit later. And if you had the choice of a different technique, which one would you prefer? The one that gives 30% 2 lines gain of uncorrected distance visual acuity, or 33%, or your standard laser procedure? Let's talk about a little bit more about this. It's been 15 years, and it is amazing in New Orleans that in this meeting I was presenting and utilizing topography-guided treatments in fixing some of the laser refractive surgery mishaps, enlarging optical zones, treating decentered ablations, treating cornea scars. We endeavored, and in your handout, we have over 50 publications in peer-reviewed literature working on extreme irregularities such as keratoconus. You can see here, again, a significant cornea scar normalized. And we know that topography-guided was designed to fix sick corneas, and it is very effective in doing that. But I want to focus here today on how we can use topography-guided perhaps to achieve better primary laser refractive surgery results. And it was during the FDA trial of topography-guided with the Alcon technology that we learned that we can get uncorrected visual acuities far better than with any other platform and any other technique reported at the FDA previously. Now, this has a lot of labor involved in it. You can, as we'll see here, the surgeon has to choose from several topographies that have to be quite uniform. There's a statistical difference of these topographies, difference between their asphericity, their axis, the amount of cylinder, and once these are validated, the treatment plan comes into play. And here, we have a difficult task. The topography may recommend a different amount of axis and amount of astigmatism to treat than our clinical refraction. So what do we do then? Clinical example. This is actually a 27-year-old physician. We'll focus on the right eye. Nowhere in what she's wearing or what we're refracting or what her wavefront gives us, she has significant astigmatism. Do we agree that there's no astigmatism in this topography? We have to validate anterior surface topography with sign fluke imaging, which does validate it in order to take into account the posterior cornea curvature. And we also need epithelial maps to validate the cornea imaging. So this is a cascade of multiple diagnostics to come up with a treatment plan that will normalize this normal cornea to the vertex, to the visual axis of the patient. So what we do here, and we reported on this, we're using topography modified refraction. So we're modifying our clinical refraction based on the topographic cylinder as far as its amount and axis. It's quite a big leap of faith, especially when we're talking about differences of 10, 15 degrees of axis and 1 or 2 diopters of astigmatism. And we are reported in Paris at the ACRS in this meeting comparing a 50% to 100% TMR, meaning going towards your topography astigmatism axis and amount, taking that it's been validated with the diagnostics that I mentioned before. And sure enough, even if we do 50% TMR, we go 50% towards the axis and 50% towards the amount of cylinder, we're seeing higher outcomes in gains of 2 lines of vision. These are very significant data for refractive surgery today, compelling, if you may. And this is because we have much less cornea and refractive astigmatism post-op and a much better approximation of the refractive error. And again, this patient had left eye, TMR, topography guided, right eye, standard clinical refraction topography guided, which left some of the cornea astigmatism in place and may require future treatment in the future. So, in conclusion, topography guided can be a more accurate, customized tool because it offers objective, reproducible measurements. It normalizes the cornea, even corneas that we consider normal, towards the visual axis of the patient. So angle kappa here is very critical. And of course, it does require multifactorial cornea imaging to validate these data. We feel that besides the therapeutic benefits of topography guided that can fix some of the problems that we saw previously, it being employed for primary laser refractive procedures can offer higher level efficacy and higher level accuracy and better visual acuity. Now, the ideal would be combining topography data with wavefront data, and we're working currently, this will be available in Europe over the next few weeks on a combination topographic, topometric, and wavefront platform that may give us even more accurate data. I know it's a lot of material to digest in 6 minutes. Thank you so much for your attention. Thank you.